Welcome back to This is Menopause. I am Dr. Christy Guepet.
And I'm Dr. Angie Pearson, and we are board certified medical doctors, certified by the American Board of Obstetrics and Gynecology, and also certified Menopause Society providers.
Yes. Last episode, we talked about the standard of care in women is not and never has been enough, and why the choice of your hormonal provider, navigator, is really important, specifically for menopause and perimenopause. We talked about AM and FM type dials where we're adjusting specific things like sleep, nutrition, exercise, as well as prescriptions to optimize how our body functions and feels. And today we're going to talk about how do you find the right navigator.
Welcome to This is Menopause, the podcast where we explore the messy, magical, and often misunderstood journey of menopause and its unpredictable sidekick, perimenopause. Together, we're flipping the script, breaking the silence, and reclaiming the power in every stage of this transformation. We are here to rewrite these chapters, to change her story.
I think the most important step in the process is how do you find the right navigator, which unfortunately so many women are looking in the wrong place. So we're hoping that we can help educate about why that's important and then how to go about doing it and what questions to ask.
You know, you cannot do this alone with ChatGPT.
No.
In this day and age, we have so much access to information, as well as influencers. So many potential for rabbit holes in this frantic attempt to feel better. So women are alone with their phones in the middle of the night seeking answers, and they really are getting in rabbit holes where we feel like the first step in feeling better is to slow down.
Slow down and think about the credibility of the person you're listening to. I heard somebody, actually a colleague of ours, state today that she would not take criticism from somebody that she would not take advice from. And I think that we're over inundated with healthcare advice. There's so many people that are not credible that are on the internet, and people are desperate. Women are desperate to find answers to how they make themselves feel better. And unfortunately, the mindset has shifted away from, okay, modern medicine to let's find something that's more natural or a supplement that's going to fix this. And I think
modern medicine has failed.
It has failed them.
Women
It has failed them.
in this realm.
Yes.
And so they're just seeking something that will help.
And they can't find anybody to help. So I understand exactly why it's happening.
Exactly.
But unfortunately, women are looking in the wrong place.
Yeah. And it's just creating noise and chaos
and confusion
in their bodies. And, you know, and frankly, our phones are probably making us sicker. So at 2 a.m. up on our phones trying to find an answer alone is not helping you feel better.
No, it's probably making you feel worse because it's then you're confusing yourself, and then you've got this drawer full of supplements. Mm-hmm. And I hear this from patients all the time. I have 10 different supplements to help all of my symptoms, and I don't really think any of them help. And most likely they don't, honestly. So how do you find the person to help you? What questions do you ask?
Yeah. So I think the first step is to slow down, try to dial back noise, and focus on that goal of finding the right person. I think that the qualities of that person are there. There probably are some general qualities to look for and some things to avoid when you're trying to find that. So we are board certified OB-GYNs. We have been advocating and managing hormones in menopausal women for over 20 years. And this has been a passion for us since early in our careers. We have clinically been face-to-face with women at really difficult points in their lives, trying to help them troubleshoot, which has given us a depth of understanding of these symptoms and the solutions. but we are unusual in that.
Yes.
And there are only two of us. And I think that the tide is turning.
How often do you hear your patients say, my other provider said this, my oncologist said this, my family member said this, my sister who's a nurse said this? I mean, how often do you hear that when you're talking to patients about hormones or just about menopausal medicine?
Every new patient that we see, and it's not just one influencer.
It's many.
It is many, and they're just completely overwhelmed. Now, the women who find us with decades experience and passion for this, in addition to attention to what science says too, they're the lucky ones.
And how do you think they find us?
I think they find us through friends, friends that they can watch feeling better. One of my patients said in her office, she noticed one of her coworkers transforming before her eyes. And she asked her, what's going on? Like, I can tell you feel better. And she said, I found a
Menopausal guide, yes, that can help me.
who's helping me. And that process for her took 9 to 12 months, but literally the women around her saw it happening. So that's one way. Certainly Google, historically has been a way that people can find us, but still it's hard for them to find us.
Well, and I think that, the whole reason we do these podcasts is to help educate. And I think that has really helped women to realize that there are people out there that dedicate their career time to just this. And I think it's important for patients to understand there are people that, so to speak, specialize in menopausal management. And that's what you and I have chosen to do.
Mm-hmm.
And so how do you respond to your patients when they say, well, so-and-so told me this, or my primary care said this, or, my oncologist said this because I had breast cancer 5 years ago. I mean, how do you handle those conversations? I'm just curious how do you respond?
Mm-hmm. So I talk about the static and the noise and how important it is to find someone you trust. If it is not me, they need to find that person.
Right.
Someone who is trained, understands with clinical experience, as well as appreciate science. And
that's key.
And someone who is willing to sit down and listen and consider details with you. And you focus in on that person
only.
Right.
Don't listen to the others. Once you figure out who that you can trust and who's got your best interest at heart and who is the most experienced and well-read, because there are providers out there who really don't know science.
Right.
And it's not really their fault. So I don't want to ever make it sound like that I'm criticizing another a colleague or another provider, whatever, mid-levels or, physicians or whatever their specialty is, or the credentials are, because, I think what the public doesn't understand is the level of education with menopausal management has been almost none, even for OB-GYNs. When you're asking your physician or your provider, whatever, okay, so how do you feel about menopausal management, and would you help me with my menopausal symptoms? How do you, I guess, how do we encourage women, not even women in our office, because obviously they're here to talk to us, about how to investigate? I mean, what questions do you ask your provider?
Well, I think the first expectation to have is that it will not be accomplished. The menopausal matrix will not be decoded at an annual exam.
It's a special time.
Separate. It can be an intro into that conversation and assessment, but the annual exam is a very specific exam, and there is not the capacity to explore
all the things,
everything hormonally at the annual. And I think that that's a really important expectation to set from the outset. I think asking your provider about their approach to menopause. I think another kind of hot question would be, how do you feel about hormonal lab testing?
Mm-hmm.
And you can read through the lines about someone's approach and how they respond to that,
Right.
because this is a realm that answers are not in black and white. And the best providers for menopausal care are going to be those who are open and curious.
Have an interest in it.
Huh.
I think it's important for women to ask, do you have an interest in menopausal management? Because if they don't have an interest in it, they probably are not well read in it, and they probably haven't spent much time, being curious or studying it. And so asking that person, that provider, for advice is probably not the right person to ask. And most primary care doctors, bless their hearts, they're so overworked and burnt out. And unless they've decided, hey, I'm really curious about this, they're so covered up with the rest of the things that they have to do that most of them don't have. I mean, it's like when my patient says to me, well, can you write my blood pressure medicine? I said, I can, but I don't read about hypertension management. And so, yeah, I may write you something.
Bridge a gap.
I may bridge a gap and give you 30 days of something till you can get in to see your primary care provider, but that's not my interest, and that's not what I read about. I don't study about that. I don't study about hypercholesterolemia. So I think it's fair to ask whoever you're trying to get help from, is this an interest of yours? And and hopefully the provider's honest, and depending on where they are in their day, or, what they've dealt with all day, that they'll give an answer that's appropriate and not make you feel like you're being dismissed, because not everybody who answers the way you don't want to hear is being dismissive. Sometimes they just don't know what to say. Sometimes sometimes it's their ego, but sometimes they're burnt out and busy, and they don't have the time for it. So it's not that they're actually dismissing you in particular. They're just trying to focus on what they think they're there to help you with.
And insurance has told them what an annual
Oh,
plan
absolutely.
is.
And you don't get, they don't get reimbursed for time spent discussing. It just doesn't happen, not in this day and age. So I think, I really want women to understand it is very important about who you ask for advice. And if you ask a family member, there's a lot of misinformation out there, and women that are still under the impression that either their breast cancer was caused by something that they took, or their aunts or their cousins or their mamas or their grandmothers was caused by.
Told by their doctor.
And their oncologist told them. My oncologist said this is because I took hormones. And I'm like, they don't really have any way to know that.
Right.
And it's probably unlikely. You probably would have had, that break in our DNA that's altered somehow from the time, we're conceived, based on our genetics, is there regardless of what we take or do. And things that trigger a cancer because of that particular part of our genome are important. It's just like people that smoke cigarettes. Not everybody that smokes cigarettes gets lung cancer. A lot of them do. And we know that that's a cause. But I think there's been this huge misinformation about, oh yeah, my breast cancer was caused by my hormones. And it's going to take us a long time to change that, especially when oncologists are still telling patients that.
Absolutely. I heard Dr. Mary Jane Minkin, when she was testifying in front of the FDA panel and around hormone replacement and cautions, she said, if women are convinced that that hormones are going to kill them, then why would doctors study how to talk to them about it? So doctors haven't talked to women about hormones. It just shut down after the WHI trial. And education in OB-GYN residencies never was good.
No.
When it comes to menopausal hormonal care. But the majority of residency was learning how to safely deliver babies
and care for pregnant women,
and surgery. The majority of our training was surgery and obstetrics.
Very little was office gynecology, and even less than that was the menopausal management of your
Right.
office patient.
But we had more than, because, I finished residency in 2003. The WHI trial was halted in 2002.
Right. I was already in private practice because I finished in 1999.
Right. But so we were trained then. The people who've been trained in the last 20 years
Got nothing.
had almost nothing. And Mary Jane Minkin, in this testimony, she quoted two studies published. One was by Dr. Wen Shin of Johns Hopkins, and it reported that in 2013, only 20% of residencies in the United States did any menopausal hormone replacement training.
Yeah. Wow.
And as of 2 years ago, only 30%. That was data reported by Peter Snatz, who was the previous president of NAMS.
Mm-hmm.
And that means right now, approximately 70% of our OB-GYN residents are not being trained in this huge segment of a woman's life.
And then so that primary care providers aren't trained.
Right.
Family practice and internal medicine.
So finding the right person actually is harder than it seems. It seems, and that's the reason women are seeking information from all
the
sides.
internet. Yeah.
I also heard a statement by a well-learned researcher about testosterone in women. And the statement was in and around the use of testosterone in women for anything other than libido.
Mm-hmm.
And her comment was, we do not have robust data to support use in women other than for libido. And that made me cringe, because it's so easy for someone in a science lab
mm-hmm.
who is looking for the gold standard in medical data, which is a randomized controlled trial,
right.
To completely knee-jerk to say, no, this should not be done because the data isn't there.
And she's never cared for a single patient.
Right.
Mm-hmm.
We literally have been in the trenches with women who are on the verge of divorce or already divorced because they can't have sex with their husband. I mean, I can think of a patient within the last 2 weeks. She had 2 divorces because she could not have sex. And it just taking away an option because we don't have
robust
data. We have really good data, and you and I have seen it change lives. And then someone may say, oh, well, this is a so-called expert in hormones. But
if you don't treat patients, you're not an expert.
Right.
I'm sorry. That's it. Because you don't have the experience to look at that patient in the face, every few months or how often you're seeing them. And then over the course of many, many years, because, I've been in practice 25 years, you've been in practice 20 years. So I think when people in that position make statements like that, and also too, this thing about robust data, when we trained, we were taught, okay, the data is robust. It was all about, the randomized, double-blind, controlled trials. And we know that there's probably not going to be any more data than there already is unless we do some retrospective studies because, the face of all that has changed and the amount of money it takes to do trials has changed. And if you don't have big pharma donating the medications, which most of these medications that we're using are compounded, that we're never going to have that robust data. But I think we do have plenty of data that indicates that it improves mood, that it improves energy, that it improves your ability to get up and move your body,
lean body mass, endurance,
along with libido,
that women
bone health.
Yes, that women are really struggling with. I saw a analysis of data done by Johns Hopkins in 1998, an evaluation of all medical data as of 1998, only 11% of all published data had been done in women only, with the intent of understanding the female body. 11% of all data. How do you have robust data when we haven't even been looking at half
For
the
data.
population?
Yes, exactly.
The other thing I thought was striking was in 1977, an FDA panel came out with a recommendation that women of childbearing years should be excluded from phase 1 and early phase 2 drug trials because they were at risk for getting pregnant.
Right.
1977, the FDA came out with that recommendation, including women who were single, women who were on contraception, and women whose husbands had a vasectomy. We completely excluded this huge group of women. So we would not have robust data in a group we haven't even been looking at.
Right.
But does that mean our lives don't matter? Our quality of life doesn't matter today? I don't want to wait around for robust data that may never happen. I'm living in my skin today, and I want to feel good.
And we want our patients to feel good.
Yes.
And you and I both, have used hormone replacement therapy. Me for probably more years than you have because of my age, but I think, and when I tell patients this is what I do for myself, it makes a big difference.
Absolutely.
It makes a huge difference. And this is what I do for myself and have been doing for myself for several years now. So I just want to encourage women to know that you have to ask your provider the right questions to try to figure out if that's the right person to give you the right answer.
It's also possible you may see an evolution in your provider real time, because I think that more and more doctors and providers are realizing that the headline was wrong.
Right. Yeah.
And so they're actually learning along with patients. And so you could possibly see that interest start to unfold in your provider over time. So I think that that's something to consider. And I heard someone say that if menopausal questions aren't addressed at the annual, then that's not the right doctor.
Yeah, I don't believe that.
I don't believe that either.
I don't buy that.
Because the annual is so specific. So don't rule out that your provider will not be a great resource for help just based on that.
Right.
Schedule a consult. You brought up supplements, somebody with a drawer full of supplements. I had a patient yesterday who came in for her annual, and between last year and this year, she is on a slew of supplements, some injections from 2 separate providers outside of me. And at the annual, she was like, and I want to know what you think. And I said, let's get your annual done, and then let's schedule a consultation.
Right.
So if you ask your provider such a question and they say, we can't do that today, that's not a no.
That's not a no.
Yeah. It requires its own attention. It deserves its own attention. I think, literally that was just an example that happened this week.
Yeah, I often, and we see this a lot, that because our demographic, my patients have aged, and your patients too have aged with us. And so many of my patients are about my age, or a little bit younger, or a little bit older. And so most of my annual visits are menopausal women. And so I do ask questions to make sure that if they're not on hormone replacement therapy, that they feel okay, that they're not having vaginal dryness, that they can have a comfortable intercourse. But I don't really go past that unless they say that unless they say, I'd really like to talk to you more, or what do you think about these things that I'm taking? And that's when I'll say, let's draw some blood work, and let's today, and we're going to bring you back, and we're going to talk about those results when you come back. And I think that women, most women, because they may not have been able to have labs checked with their other providers, or they might have been told it doesn't really matter. They're just encouraged that somebody's going to draw their labs. And I had a patient this week who was a new patient for hormones, and you could just see her, and we hadn't even started anything yet, but you could just see her countenance change when she said, I'm just so happy somebody's listening to me. And she was here just to talk about hormones. So that she wasn't here for a checkup. And then she said, okay, I have something else to tell you, which is something she wanted to confide in her provider that she hadn't felt comfortable for, this was her second visit, that she had not felt comfortable telling me the first time. But when she came back and we talked about her lab results and what I thought, might be the best options for her, she just felt this guard just completely went down. And she said, okay, I have something else I need to tell you. And it was just something private about her medical history that she just, didn't feel real comfortable discussing. But you could just see her shift in her demeanor because she just felt so heard and so safe.
Yes.
And I think that women are so desperate for somebody to help them when they get to that point. And most of these women are in their early 50s, most of them. That doesn't mean that your symptoms can't start, before then.
Late 30s,
right.
40s, yeah.
But I think that they're in the throes of it, and they're just so relieved to find, or at least think, okay, help is on its way.
Yeah.
Because we hadn't started anything yet, but she felt like, I'm going to get better. And this brings to discussion too, this whole thing about labs and providers telling patients, if they did do labs, okay, your labs are completely normal. There's nothing wrong. Because I drew her labs at the first visit, and at 2 weeks later, because her labs didn't make a lot of sense to me and she was 52, I rechecked them, and they were drastically different just in 2 weeks.
Which speaks to the hormonal chaos
roller coaster
that she has been white knuckling through. So part of you just said she's in the throes of it by early 50s is because she's been trying so hard to get through and keeping it all inside. I do think it is therapeutic to finally find that right provider, a hormonal navigator, to sit down with and unload all of this that she has been trying to manage on her own, with Google at 2 a.m. And even if we don't draw a lab or we don't start a prescription, just being seen and heard, and finally having hope. So for us, the depth of our understanding of that patient is going to get better and better over time. Each consult we have, you always use the analogy of peeling back an onion. You knew much more at that second visit than the first because that comfort level starts to develop. So this is not a one and done process. That is a really important expectation to change.
Right.
The annual exam once a year is not going to do it. This requires ongoing attention, and you want your provider to want to know those things so that the nuances of not just hormones, but also other medicines. A woman might have been on the same antidepressant since, she was postpartum for 20 years on the same antidepressant, and that's never even been looked at again. And we've been doing this for a long time. Some of the antidepressants that were started with very specific FDA approvals aren't optimal for women in menopause and perimenopause. But peeling all of that back takes time.
Yeah, not even 1 or 2 visits; it's multiple.
Yes,
and and that brings to mind too, how many women were put on antidepressants to treat their perimenopausal symptoms, that roller coaster of the highs and the lows of the last 25 years. Many. Many.
And it helped. It did.
It did.
It was particularly when providers weren't willing to put them on hormones. Thank God we had something.
I know, but then what did that do to their libido?
Bingo. And their weight.
Yeah.
Paxil is the medicine that went after the FDA approval.
Yeah.
For menopausal symptoms.
PMDD. Yeah.
And Paxil is associated with weight gain. It's an excellent choice for a patient with anorexia.
Right. Well, and almost all of those SSRIs kill libido.
Yeah.
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 And the ability to respond sexually too. So not just the lack of desire, but just the inability to respond. It's just they're sexually numbing in most patients. So yeah, we may have fixed some of the mood lability, but we didn't fix everything else. We made it worse. Yeah.
Well, so obviously you are my hormonal navigator, and I suspect I'm yours. In your journey, and as you went from perimenopause to menopause, what would you say has been something that I've helped you with? I certainly know what my answer would be, vice versa. But what would you say that would be?
So I think one thing you did was help me realize I needed more estrogen. You know, I had been using some testosterone therapy for multiple years to just kind of even out the roller coaster. And when I would check my labs, I would still see that I had some estrogen on board. It, but it was fluctuating quite a bit. And the amount of metabolic syndrome that occurs as those estrogen levels start to decline or fluctuate drastically is really significant, especially for women that are predisposed to it. And so I think me fighting my metabolic syndrome and thinking I don't really need any extra estrogen was wrong.
Because you were killing it when it came to exercise.
Killing it.
You have taken such good care of yourself, and time kept ticking away, and that metabolic issue started creeping in just because of age.
Just because of age, and probably estrogen levels declining too.
And estrogen helps our metabolic health. It helps so many things.
So I think that was a big one as I was, trying to, I guess, skirt along and for different reasons too. Breast tenderness with estrogen, thinking about, okay, a little bit of water weight gain, all these things that get in your head. My mother died of breast cancer. And even though I knew that estrogen was not, the trigger for that, now my mother was convinced it was, but she's been gone for a long time. I still was trying to just ride that tightrope about maybe I need just a little bit, maybe I need a lot of bit. And now I've let that guard go because I realize, okay, I'm almost 57. I need as much estrogen as I need.
Yeah.
Yeah.
For brain health and metabolic health. And
all the things.
All the things. Our skin.
So what about you?
So I think I've always been active too. Exercise is a huge form of therapy for me and always has been. But I was never a weight trainer. That's been something you've been committed to your whole life. And you would always just chirp, you need to be lifting weights. You need to be lifting weights.
You need to be lifting weights.
And lifting weights for the last 2 years, I have definitely seen the composition of my body change significantly. And now we know weights are much more important than we knew when I was in med school. Weight training is important for sleep. It decreases the risk of dementia. It improves metabolic health. And I think one of the most surprising symptoms for me personally has been my muscular aches and pains, my arthritic symptoms, so joints and muscles. I am going to be a lifelong hormone recipient because my muscles and my joints need it. It helps with tissue and skin and, hair and bladder health. And
those receptors are all over our bodies.
I'm talking about pain.
Yeah.
I need my body to move.
Yeah. And that you said you're going to be lifelong. How often do you get patients that ask you, how long do I have to take these hormones?
Yeah. Well, and I'm a minimalist in general. If something's not broken, I don't want to go break something. So if I don't have I've always said, if you don't have a headache, don't take Tylenol. If you have a headache and one Tylenol fixes it, take one, not two.
Which is kind of where I was with my estrogen therapy for a while.
Right.
Yeah.
which makes sense.
Mm-hmm.
But estrogen is different. It literally changes us from children into women. It is an essential part of our essence.
And it prevents long-term disease.
Yes.
Now we know,
Mhm.
we have good data to show, because we withheld hormones from, well, not we, but many withheld hormones for women for the last 25 years, and those women died of other causes. So what I tell women is, my answer is indefinitely.
Mm-hmm.
You'll use it indefinitely,
Yes.
because you don't stop at any certain age.
My brain is always going to need it.
Mhm.
My muscles are always going to need it. Yes.
Your bones are always going to need it.
Yep.
And so I don't think that we should ever tell a woman, okay, you got to stop your hormones.
Yeah.
You may need to find a different route. If you were taking oral estrogen, obviously I'm going to encourage you to come off of that, because that's a whole different, drug, so to speak.
I mean, that speaks to something within the last month, I've seen a couple of patients, one who actually saw a menopause certified provider who came in who was on oral estrogen.
Oof. Yeah.
A woman who was 35, 36 years old, BRCA positive, multiple family members with breast and ovarian cancer, ultimately went through bilateral mastectomy, complete hysterectomy with removal of both ovaries. And she comes into me on 1 milligram of estradiol by mouth.
Not the best option.
It's not. And
cheapest option.
Right. It is the cheapest option. And it's better than nothing.
It's better than nothing.
But she needs a hormone provider, somebody who wants to get into the details of her life and help her, so that she can enjoy it. So even sometimes it's complicated when you look up a list of certified menopause providers. We're not all equal with our
That's true.
with our interests.
That's true. And so how did you help her?
So number one, we started by listening.
Yeah.
She came in the second visit and literally was in tears. Just because, I mean, all I had done at that point was say, we're not doing a pill. So we can try a patch, or a vaginal ring, but your vagina needs estrogen.
Yes. Most
like
importantly, yes.
2 years ago,
Yeah.
when all the surgery happened. So I was sent in a fem ring, and even before we started her on testosterone, I mean, she had not had sex with her husband at 36 years old, in a couple of months, because of how painful.
Yeah.
And that's
a marriage killer, especially in a young relationship,
Yes.
especially.
There you are with young kids running around, two adults and busy working. You got to find some way to connect to this person, that you've committed to for life. And if you cannot connect intimately, it is, and you can have patience and, in a relationship and loving and understanding and compassionate for each other, but that is still it's just
at the end of the day, it still has to be addressed.
Yeah.
Yes.
So ultimately we started our own testosterone. The tears have gotten bigger and slower, but each visit there are tears because she feels so much better and she has so much hope. And when she looks at her daughters, she can have hope that one day, if they end up having to make similar decisions that she did,
which they might, if she's
they're not going to be 2 years
into that,
because
of her genetics.
Yeah.
Yeah.
So if this is you, we see you. We know that you're there at 2 a.m. Trying to feel better. And we are here and we are ready to listen. And there are other doctors out there like we are. I'm not going to tell you that it's super easy to find, but we are here. So keep trying. Keep trying. Don't give up.
Okay, so let's talk a little bit about why OB-GYNs are hesitant to write medications for the last 25 years, hormones. the difficulty of that specialty, how litigious that specialty is, and the workloads of that specialty. So I don't think the public understands.
Yeah. OB-GYN is an incredibly intense profession. And if you'll think, I mean, when we were in training, 90% of practicing OB-GYNs were men. Today, over 80% probably are women, and oftentimes those women have kids at home and have full-time jobs at home too. The bar of expectation for the outcome in labor and delivery is perfection. And if a bar is perfection, you're going to have constant physical and emotional strain from that all day long, every day. So, these are, for the most part, women who are often up all night long, delivering babies, running back and forth, life and death of at least two people are at stake with the decisions that they're making and the skills that they're using. That it is incredibly demanding, both physically and emotionally, and spiritually. And you do that all night long, and then you go into a clinic to do pap smears and to see somebody who's 28 weeks pregnant, and then you have someone who might be struggling with postpartum depression, and then you've got someone who's going through perimenopause and menopause and on the verge of divorce. The pressures of that provider, it's unlike any other profession. Not to mention the litigious nature of issues around that specialty, because the bar, the only appropriate outcome is perfection. And if something happens in labor and delivery, that is a major failure.
Life-changing, career-changing.
It can
event,
be career-changing. And there's a constant sense of, oh my gosh, am I going to have a career-ending lawsuit?
For fear of litigation.
Yes.
And now you've been told that hormones cause breast cancer,
right,
and you're not supposed to write them. So you probably are not going to spend any time, because for one thing, you're so overworked.
Yes.
At home and at your job. And the mindset that hormones cause breast cancer, and the last thing you want to do is add to your potential for litigation when you're in a specialty that is so at risk for that. And I understand why they're like, no, we don't. First of all, we don't have time to go back and learn and either relearn or unlearn what we've learned. And until the mindset shifts for everyone, I don't want to put myself at any more risk.
Right.
So I understand
guidelines
that.
really, feel like protection.
Safe.
They feel safe. So if you're inside this box of these guidelines, then you feel like you're up against a backbone of some safety. When you go outside of that box,
You're exposed.
Then it doesn't feel safe. So when you're talking about testosterone or long-term hormone replacement outside of these guidelines, because this headline has been so gripping for a couple of decades.
Yes.
That's a hard thing to shift. So we really want people to have awareness and compassion
For their position.
for that position. Not to mention the fact that they weren't even trained in residency. 2 years ago, 70% of residency in the U.S. didn't cover menopause and hormone replacement.
Yeah, no menopausal education. So I think it's important, because I think people get really, they get disenchanted with their OB-GYN.
And think that she doesn't care.
She doesn't care. So he or she doesn't care. So I don't want, I just want to make sure that we explain that and we bring light to that, because I think, of all the specialties, I think it is probably the most demanding. I mean, maybe a cardiovascular surgeon, maybe, equally, but I think everybody thinks, oh, it's just a fun specialty. You bring a new life into the world, and it's great when it's great, but when it's not, it's really bad.
Nothing is bad.
And it's the workload is very heavy in that specialty. So anyway, I just wanted us to kind of
it's a really
bring some light to
important
that.
point about why it is so hard.
So, it's about persistence and patience, and it's, we want to encourage women to to find the right provider and hang in there. Once they do, to hang in there and keep going back.
Slow down. Stop chasing squirrels.
Because there are a lot of squirrels on the internet, especially on the social media.
Yes.
Mhm.
Get serious about finding the right navigator. Once you find that navigator, let them know the weeds.
Let them see through all the layers. Let them peel your onion.
Yes.
So
And turn down the distracting,
the noise.
the noise
Turn down the noise.
outside of that relationship. And then keep going back.
Yes.
Make follow-up appointments. Pay attention to how each of these changes is working. So tuning in rather than tuning out. Women are experts at tuning out symptoms.
Oh, yes, over the course of our lives, because we just had to keep going.
Yes.
So the only thing we want you to tune out is the noise.
Yes.
Tune out the noise,
Tune
but pay
that
attention
out.
to everything else.
Tune into yourself. Find the right person. Pay attention, and just be filled with hope, because we know the best is yet to come.
Yeah, so follow along with us.
Yeah. For the ride of our lives. This is Menopause.